Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features audience questions from a webinar for pharmacists on overcoming barriers to PrEP uptake, featuring Dr. Milena Murray, Associate Professor and HIV-ID Clinical Pharmacist at Midwestern University College of Pharmacy in Wheaton, Illinois, and Dr. Kevin Astle, Assistant Professor and Clinical Pharmacist at the University of South Florida in Tampa, Florida. For more information about Drs. Murray and Astle and this program, and to access the downloadable slides, please visit the links in the show notes for this episode. Now let's get started and hear our first audience question.
Our first question comes from Matthew, who is wondering about the on-demand recommendations for TDF and FTC. And currently it's recommended for the MSM population, but why is it not recommended for cisgender women who may be at risk for HIV through receptive anal sex? Because this might be a missed opportunity for some cisgender women at risk from receptive anal sex who want intermittent HIV prevention. So I'll go ahead and give my thoughts on this. I believe that it's to do with the data that we have. So currently the only data that we have is in the MSM population. And while, we could assume that it might work, we don't want to because we don't have any data in that population. So at this time, it would not be recommended. Hopefully in the future, we might have some data for that. So our next question comes from Jean, and I'll give this one to Dr. Astle. What are your recommendations for communicating with non-English speaking populations who may not be able to read English but are searching for help and assistance with PrEP?
Yeah, thank you, Jean. That's an excellent question. The best is to work with the resources you have at your institution. So whether that's translator services or if there's anybody who works in a pharmacy or the clinic setting who is a native speaker, finding some ways to engage with the community. I live in Florida and we have a heavy Hispanic community here with a lot of Spanish speaking individuals who don't speak English, don't understand English very well. So it's really trying to find those champions that we can. So not just for PrEP, but for communicating with patients to really expand these education opportunities.
Great. Next question is from Jason. This is about long-acting cabotegravir for PrEP. So do we think that pharmacists are going to need to be in charge of visits for long-acting PrEP injections, specifically the actual injection? And so I'll go ahead and give my thoughts first, and then I'll give it over to Dr. Astle for his. So I think that pharmacists play a huge role in medication acquisition, in counseling, in making sure that patients return on time for injections. However, I think the actual injection of the drug is going to be very specific to the clinic. So for example, even at Northwestern, in some of our clinics, nurses do the injections. However, in other clinics, they prefer to use our infusion centers for the patients to go to get injections. So I think this will depend on what the capacity is at each clinic, what type of visits that you have. And then, of course, depending on, local and state laws about if pharmacists are actually able to, give injections of that kind to patients. So Dr. Astle, do you have anything to add to that?
Yeah, I would just add, in my experience, I've worked on the back end, the nursing team and providers to really work through the process with the cabotegravir long-acting injection. It is a little bit more complex to acquire the medication. So really working on training the team to understand what's needed, the insurance billing differences. So really, formulating the plan on the back end, whereas we leave the injections to the rest of the medical team, or as Dr. Murray said, like an infusion center, some other way to engage in that aspect.
Thank you. Our next question comes from Rebecca, and this is about the new CDC recommendation for routine HIV RNA testing. Why is that needed if somebody is adherent to PrEP?
That's an excellent question. With our oral PrEP options, with the routine follow-up might be more leeway there, but with our long-acting injection, we did still see some breakthrough infections in the study. So it's really ensuring that we don't have any kind of detectable HIV RNA. And so that if we do, to switch to treatment right away. So there is potential for breakthrough there, but it is potentially an unnecessary barrier there, as you pointed out.
So I'll add on to this too. We have to think about injectable PrEP monitoring potentially different from oral PrEP monitoring. And so definitely with the injectable in clinical trials, they saw that there were some infections that would have been picked up sooner if the HIV RNA was done, because there's this syndrome, Levi syndrome, or Levy syndrome, depending on how you want to say it, where the antibody almost flickers on and off. So the antibody might not come back positive, but the HIV RNA would be, greater than undetectable. So they're really recommending that for early detection of HIV, because then what that allows for is if we detect it earlier, we're not giving somebody a single agent to treat HIV, and we're greatly decreasing that risk for resistance. So yes, it is definitely somewhat of a barrier. What I would say, though, is if we truly believe it's the best practice, we need to keep pushing for that to be covered with all the other PrEP monitoring and not just push it to the side, and just to continue trying to move forward with what we think is the best for patient care. But that is definitely a very, very debated topic currently. So thank you for asking that question. So our next question is from Melissa, and I'll give this one to Kevin. What are your recommendations for engaging with pregnant people who might want access to PrEP in the pharmacy setting?
So I think that's a really interesting point you brought up there. And depending on states, I believe we have about 13 states now with specific PrEP legislation procuring PrEP through the pharmacy, which is really expanding this and making this a much more kind of relevant and timely question. As far as recommendations, I would kind of look at doing an abbreviated sexual history with the patients, because if they're pregnant, we do know that there's some kind of positive sexual history there. So trying to understand what their risk factors are. If they have a partner who might have an unknown HIV status, if it might not be a long-term monogamous partner. So just having those conversations with patients and really trying to increase awareness that PrEP might be a good option for them if they're not comfortable or aware of their partner's HIV status. Dr. Murray, if you have anything to add on there, please do.
No, I think that's very, very comprehensive. I think one of the most important things that I will say is that, we have data that show that people have touch points with the healthcare system almost 7 times before they may have an HIV diagnosis. And so each of those times that a pharmacist speaks with someone, either at community or clinical or any healthcare setting where someone is assessing someone, they should talk about PrEP, because I think that you go in, someone mentions it to you, and you have 20 other things on your mind. And it might take the third or fourth time before it actually sinks in, and you might have that discussion just internally, like, oh, 4 people have mentioned I should be on PrEP. Maybe this is something I need to think about because of all the stigma and everything. So I think it's very important for everyone to think about those touch points, because we don't want to have those missed opportunities for sure. So one more question that I'll give to Dr. Astle based on the data from Marrazzo and colleagues that you presented, which was from CROI. Do you think that we can actually de-emphasize adherence with cisgender women now, given the data that you presented?
Yeah, so we saw on that slide for that, patients that had the full daily adherence, we saw no HIV infections. And then for patients that took 4 to 6 doses a week, which is really relatively low for adherence standards, we still saw only a 0.13 infections out of 100. So really what that's saying is essentially, again, 98, 99% effective for that population. And so as a pharmacist, I really don't like to de-emphasize adherence. I think we still need to emphasize adherence, but I think we can approach our cisgender women in a similar way that we can with our, whether it's the MSM population or really looking at our anal receptive sex population. There's still so many mysteries and questions about the effects of the decreased concentrations in vaginal tissue and kind of that bigger challenge of achieving those steady concentrations there. So I think just further studying additional data will be helpful, but I don't like to de-emphasize adherence ever, personally.
I agree. I think, injectable adherence is a little bit of a different conversation than oral PrEP adherence, right? So I think it's, maybe we're less concerned about adherence day to day because of injections, but we still need to make sure that those on-time injections are occurring. So definitely agree.
Thank you very much to Drs. Murray and Astle, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program, on the CCO website, including downloadable slides and on-demand videos. Click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you, and have a great day.